Hello, everyone. The Coordinating Center for the National Drug Early Warning System, sponsored by the National Institute on Drug Abuse, is pleased to welcome you to part 2 of our two-part series on illicit stimulants. Today's topic is cocaine. The NDEWS PI is Dr. Eric Wish, and our NIDA project scientist is Moira O'Brien. I believe that both of them are in the audience with us this afternoon. My name is Erin Artigiani, NDEWS COI, and Barbara Kerr, Marwa Al-Nasir, and I will be the facilitators for this webinar. We are all a part of the NDEWS Coordinating Center team, which is based here at the Center for Substance Abuse Research at the University of Maryland in College Park. For those who are interested, you can find detailed information about NDEWS, recordings of our prior webinars, and invitations to future webinars on our website at www.ndews.org. You will also find instructions for how to join our NDEWS network and participate in ongoing discussions with more than 1,400 experts and concerned citizens from across the US and many other countries. So I encourage you to join us in the network if you're not already a part of it. We developed the NDEWS Presents webinars as a way to work with leading substance abuse experts to explore emerging drugs and timely drug-related topics. Today, we are excited to be joined by 3 presenters addressing historical and current trends of the use of cocaine in the United States. Our first presenter will be Jim Hall, a drug abuse epidemiologist at the Center for Applied Research on Substance Use and Health Disparities at Nova Southeastern University. Jim will provide a national overview of cocaine use from 1880 to the present. He will be followed by 2 of our NDEWS Sentinel community site epidemiologists, Dr. Denise Paone from the Bureau of Alcohol and Drug Use Prevention, Care, and Treatment at the New York City Department of Health and Mental Hygiene, and Dr. Marcella Sorg from the Rural Drug and Alcohol Research Program at the University of Maine. They will each present on recent changes in cocaine trends in their NDEWS Sentinel sites. This webinar will be approximately 90 minutes long, and we encourage you to submit questions during and after each of the presentations. However, please do not raise your hand. Instead, we request that you post your questions in the Q&A box through Zoom. If you submit them in writing, we will be able to get back to you and answer your questions about the availability of the recording and the slides and other things like that along the way. And then we will share your other questions with our presenters after all of the presentations are complete during our Q&A session. So we welcome you all to our webinar today and hope you enjoyed our speakers, and I will turn it over now to Jim Hall for his presentation.
Thank you, and good afternoon. Let's begin with a look at the 4 phases of a substance use disorder epidemic. If we were to graph an epidemic, it would, on the vertical axis, show the prevalence of use, whether it's the number of drug users or the number of frequency of drug users, as well as it could be measuring the number of serious consequences such as death, medical emergencies, addiction treatment admissions, or crime cases. And across the horizontal axis, we have time. For this model, we're using just the period of 10 years for convenience, but a drug epidemic can be as short as 10 weeks, or 10 months, or 10 years, or multiple decades. Even over multiple centuries, as we'll see. And the 4 phases of that epidemic begin with an incubation period. And this is the time when a new substance may be introduced, and already known users of other substances give it a try. Perhaps their dealer has a new source, and they get into some trouble. They find out a little about what dose to take and what not to take and what to try to avoid, and word gets out. As well, at about the same time, we have the traffickers who recognize the potential new market, and we move into a changing time period called the expansion phase of the epidemic. Now, as this goes on, positive news about the drug, its experience, or its pattern of use is generally in the public awareness. And pretty much the expansion phase will last until everyone who's willing to give it a try does so. And near the end of the expansion phase, we have a greater awareness of increasing numbers of adverse consequences that are going on. And that leads to people stopping in any initiation or even first use of the drug. And people who may have already been casual users may just stop on their own. Others may seek treatment and enter recovery. Unfortunately, others may die. But this leads to a period generally of high peak, but a plateau level for several time periods prior to a slow decline period over several of the key time periods. So this is what a basic drug epidemic may look like. Key factors contributing to a drug epidemic fit both into supply and demand vectors. From the supply side, we look at issues such as production, where a drug is grown, or whether it's chemically manufactured or grown and chemically manufactured as a synthetic or semi-synthetic. What are the patterns of trafficking to get from that site of production to the site of consumers and sales? What is the price of the drug? Is it affordable? What is its purity and potency? And what is the level of profit for the supplier of the drug? Availability of it, is it readily available when consumers want it? And more recent issues related to the supply vector involve issues such as poisonous contamination or street drugs laced with fentanyl analogs, as we've been hearing about and we'll talk more about today. On the demand vector side, key contributing factors include just personal attitudes, and particularly for youth, this is important in terms of perceived harmfulness or perceived wrongfulness, as well as acceptance by others. The desired effects of the drug are a key factor in the demand side of the equation, along with the adverse unwanted effects of serious withdrawal or being dope sick, as in the opioid epidemic. And this withdrawal period creates strong craving and increases demand among users for more of the drug. Public consensus has a great deal to do with how the public in general views substance use and whether it's considered an acceptable or unacceptable behavior. The affordability of the drug is certainly a key factor, whether users will be able to afford the cost of this substance. As well, rapid onset of action is usually a desired result. Users often want to have the effects as rapidly as possible. And finally, access to supply of the drug is a key factor in the demand equation. In reviewing the historical cycles of cocaine use, we note reoccurring patterns of cocaine epidemics over the past 139 years, waxing and waning in cyclical patterns of changing numbers of users and serious consequences. Our bicyclists here are helping to demonstrate the waxing and waning and the cyclical nature of the epidemic. If we were to graph the patterns of cocaine epidemics going back to 1880 until the present day, it would look something like this timeline. Now, this graph is not a quantitative measurement of any indicator. We've certainly not had indicators of cocaine use going back over 100 years. But this is based on following both the social literature as well as medical historical documents of the time periods. And we note these key periods of cocaine activity in our past 2 centuries. The first cocaine epidemic in the United States takes place from about 1880 to 1920. And then we see a sharp decline in cocaine use during the Depression and World War II and the post-war decades until about the mid-1970s, when we see the second major cocaine epidemic outbreak in the country, which has really lasted to the present day and has seen up and downward trends in the various indicators, but still been at high proportions since the latter quarter of the 20th century. Since the 15th century, Andean and South American native people have chewed coca leaves to relieve hunger and dispel fatigue. In 1859, the alkaloid cocaine was isolated for the first time by the German pharmacist Albert Niemann. Another German health professional, a physician, Dr. Theodor Aschenbrandt, with the Bavarian Army, whipped up a quick cocaine and water solution that he administered to an exhausted, collapsed soldier, who the doctor then reported in his medications that the soldier cheerfully resumed the march. And the doctor saw this as a powerful medication to have available, particularly for the Army. Sigmund Freud at the time considered cocaine a magical drug. He recommended it to his family, his friends, and colleagues. And because of the numbing effects, cocaine became a standard treatment for eye disorders and a local anesthetic for minor surgery as well as dentistry. And by 1863, a new product named Vin Mariana was introduced. It was composed of coca leaf extract in Bordeaux wine. It gained great popularity internationally. Even His Holiness Pope Leo XIII awarded a gold medal in recognition of the benefits of Vin Mariana, which was a popular French tonic wine. Its advertising stressed that it fortified and refreshes the body and brain, as well as restoring health and vitality. The first cocaine epidemic from 1880 to 1920 had an introductory phase, and that was marked by sirens in the background and a drug rapidly gaining acceptance. In 1884, purified cocaine was commercially available for the first time in the United States. Its wholesale cost was very high at the time at $5 to $10 per gram, but fell to 25 cents a gram until about the beginning of World War I. And that price is compared to an average wage at the time of about 20 cents per hour. And the retail price of cocaine in the first 2 decades of the 20th century ran about $2.50 a gram. Cocaine became popular in the United States. It was sold from pharmacies and drugstores and grocery stores, saloons, and sold by patent medicine vendors. Freud published 5 papers about cocaine during his career. And increasingly, some physicians believe that cocaine actually reduced the cravings for opiate addicts and alcoholics. It was encouraged by medical authorities and entrepreneurs as an elixir for the masses. It was touted as a panacea for melancholia, neuralgia, hysteria, and even nervous afflictions. In fact, already prepared syringes with cocaine solutions were sold ready for injection. In 1885, an Atlanta pharmacist named John Pemberton registered a trademark for a new product which he called French wine coca, or the ideal nerve and tonic stimulate. 1 year later, he renamed his product to simply Coca-Cola. And as the ad from the time shows, just take as a prescription 1 glass of Coca-Cola when weary and with shopping. It imparts energy and vigor. Also note the advertising specifically to women. In 1887, the noted neurologist at the time, William Hammond, introduced his cocaine wine, which contained 2 grams per pint of wine instead of the ½ gram of cocaine that was in the original Vin Mariana. This is 4 times the amount of the cocaine. By the 1890s, we're beginning the decade of hedonism and creativity, and reports of cocaine addiction become common in the medical literature. In the late 19th and early 20th century, we also are entering the era of bacteriology, which allowed for the prescribing of specific medications for more illnesses. Thus, snake oil and general elixirs and patent medicines with cocaine and opioids had less of a demand, as now more specific bacterial medications, antibacterial medications, were brought on to the scene. In 1903, there was, I love the name of this government panel, the Commission on the Acquisition of the Drug Habit. And that commission declared that cocaine, which was once favored by the upper class professionals, was now being used mostly by bohemians, gamblers, prostitutes, burglars, racketeers, and pimps. This shows an example of the placing of stigma on the users of substances as we have various shifts in drug policy. As cocaine use increased, so did its abuse. And chronic abuse led to paranoid delusions, insomnia, malnutrition, and nasal septum ulcerations. In the beginning of the 20th century, we really begin the regressive stage of cocaine. In 1903, Coca-Cola removes cocaine as an active ingredient from its product. However, there are extracts from coca leaves that were still involved in the ultimate recipe. By 1906, the Pure Food and Drug Act only required that cocaine be listed as an ingredient in over-the-counter remedies. And that was the only restrictions it placed on cocaine. And during the end of the first decade of the 20th century, cocaine also becomes the target of the temperance crusade. So it wasn't just alcohol prohibition that was being sought, but stricter regulation and control of narcotic drugs, of which included cocaine at the time. In 1914, by 1914, all 48 states at the time had anti-cocaine laws. And the National Journal Medical Record reported that there's no such thing as an occasional or moderate cocaine user. The line is very sharp between the total abstainer and the fiend. The Harrison Act, passed in 1914, actually took about 5 years until 1919 and several court challenges before it went fully into effect. But it was the nation's first major anti-drug law. And it classified cocaine as a narcotic, along with opium, morphine, and heroin. And it permitted the sale of cocaine only by prescription from a physician, and banned any traces of cocaine in general patent medicines. Calm between the epidemics lasts from about 1930s to really the mid-1970s, when the non-medical use of cocaine was nearly non-existent. References to cocaine rarely appeared in movies or music and literature of the time, and if so, it was portrayed negatively. By example, in Cab Calloway's 1931 song, Minnie the Moocher, Minnie was a low-down hoochie coocher, but she took up with a cokey named Smokey, and it didn't take long for Smokey and Minnie to wind up in the county jail. And it wasn't too long after that, the poor old Min was kicking up daisies. Public attitudes towards all drugs was downright antagonistic during the Depression and war years. And in the 1930s and 1940s, we gradually saw mandatory drug education disappearing from America's public schools. In the 1950s, we had non-medical use of cocaine being nearly non-existent. Anti-drug laws increased in severity during the 50s. It was the era of drug intolerance. Cocaine use dwindled, reaching perhaps about 50,000 annual users of cocaine by the late 1950s. Personal knowledge of a so-called dope fiend was unusual for the vast majority of Americans during the decade of the 50s. And cocaine prohibition worked because of a strong public consensus. And cocaine in the 1950s was considered a problem we used to have and has now been almost eliminated. The noted drug historian, Dr. David Musto, before his death in 2010, stated that the people who had lived through the nation's first cocaine epidemic knew that the euphoria induced by the drug was a dangerous delusion. When cocaine reappeared in the 1970s, few people remembered the previous American experience because the earlier generations that had learned a hard lesson about cocaine were no longer around. Cocaine's notorious reputation died with them. By the 1970s, America was ready for another fling with this most seductive and dangerous drug. And as Dr. Musto pointed out, those in denial of history tend to repeat it. And 1971 marked a major turning point in the cocaine as use epidemics in the United States. In 1971, law enforcement seizures of cocaine surpassed those for heroin, and the number of cocaine users and consequences of its abuse would steadily climb until the late 1980s. Cocaine's second epidemic is launched as expanding cocaine use among young adult users of other illicit drugs in the late 1970s and by adolescents in the early 1980s led to the outbreak of a second national cocaine epidemic. In the incubation phase of that period, the first to try cocaine were already users of marijuana or perhaps the sedative hypnotic Quaalude 714, methaqualone, or even purple microdots, which were tiny little purple pills that were supposedly synthetic mescaline, but were actually a low-grade LSD, and used in the disco scenes of the late 70s and early 80s, at also the beginning of the time period of the introduction of MDA and then MDMA as ecstasy, which was actually any number of stimulants sold at the time and given that street name. But users of these substances were the most likely to move into the expansion phase of the second cocaine epidemic. In the early 1980s, cocaine in the United States was chic. It was expensive. The government said it was non-addictive. Most considered it relatively safe, but really expensive. And the Time magazine cover from July of 1981 shows cocaine in a martini glass with the caption, "High on cocaine, a drug with status and menace." But by the mid-1980s, Hurricane Crack would come ashore. A key factor was the US government banning the shipment of ether to Colombia, which could be used in the finishing process of converting coca base to cocaine hydrochloride, the white powdered salt. And as we cut off the supply of ether to Colombia, the suppliers moved their unfinished coca paste bazooka through the Caribbean and into the United States for processing with the ether that was more easily obtained in those areas. In the Netherlands and Antilles, as well along the Caribbean trafficking nations, the bazooka was mixed with high potency 151 proof rum and probably a baking soda mixture to create a smokable cocaine product. Then the producers of cocaine in Colombia introduced benzene washed cocaine instead of ether washed cocaine. But for the first time, consumers of the drug in America could tell that there was something different. It smelled like diesel fuel. And benzene washed cocaine brought in a lower retail price for the drug. And a baking soda base was introduced to the Caribbean populations, as well as their activities moving into South Florida. When benzene washed cocaine was cooked into crack, the benzene escaped and the unpleasant odor was lost. Crack accelerates all the consequences of cocaine abuse by bringing in a cheaper, more readily available product that escalates the cocaine epidemic to a larger population. So that by the mid-1980s, cocaine is known as killer cocaine. It's the addiction from hell, with crack monsters in the street, and it was considered the nation's #1 drug problem. And by 1986, Newsweek magazine considered it in a front-page editorial as the nation's #1 problem. A month later, Time magazine had its second cocaine cover in September of '86 of Drugs, the Enemy Within. In more recent years, cocaine production peaked in 2007 at about 630 metric tons in Colombia, and then saw steady downward trends in production until 2012, and then started to rise again the following year, going up from 305 metric tons in 2013 to 910 metric tons, as shown in the blue bar graph, in 2016. And along the same timelines, we see the red line graph showing the number of first-time users of cocaine, which got as low as 601,000 in 2013, but nearly doubled to 1.1 million by 2016. And of course, you can only be a first-time user once. And the green line graph shows the number of those first-time cocaine users that were first-time crack users in the period. So that we see that the recent increase in cocaine use is primarily among users of the snortable powder cocaine rather than smokable crack. First-time use of stimulants in general, we note that in 2017, the number of first-time users of cocaine decreased by 100,000 from the previous year down to an even million, with first-time users of methamphetamine being at 200,000 approximately, and prescription stimulant users somewhat like cocaine at a non-medical prescription stimulant abuse at 1.2 million. Now, of course, you can only be a first-time user one time. So the other critical prevalence question is, what are the total number of users? And this graph shows the total number of users of stimulants in the past year, of any use, even just one time in the past year. And we see that in 2017, there were considered nearly 6 million Americans who were active cocaine users over the past year, and over 1.6 million methamphetamine total users, and nearly 6 million, like the number of cocaine users, prescription stimulant non-medical misusers, for a total of over 13 million stimulant users reporting in the United States. However, some of these may be the same people. In 2017, approximately 2.2 million people aged 12 and older were current users of cocaine. This number represents just less than 1% of the total US population aged 12 to 112 and above. But we see on the line graph that the highest proportion of cocaine use is among young adults aged 18 to 25 years, where nearly 2% of that population are past month. This is in just the last 30 days, which is a smaller number than, of course, the past year total users. We also see that adolescent use has decreased in the last 3 years, while adult use has been on the increase, particularly among young adults. The blue bar graph shows the number of national cocaine overdose deaths going back through since 1999. And we see that just in the past 10 years, the number of cocaine deaths nationally have doubled between 6,500 in 2007 and nearly 14,000 in 2017. Now, the green line graph across the blue bars shows the proportion of those cocaine deaths which also were detected with an opiate present on board. And the yellow line graph shows those specifically with a fentanyl analog. And so we see that the rise in fentanyl analogs and opiate use is a key contributing factor in the rising number of opioid deaths containing cocaine. By example, here is a look at the 2012 cocaine occurrences in the state of Florida in the year 2017 that were ruled by local medical examiners to be having been caused by cocaine. So these are deaths in which cocaine was considered the cause of death. But we see that nearly 65% of those cocaine deaths had some form of a fentanyl on board, and 30% had ethanol or alcohol on board. Another 28% had morphine, which very likely was also heroin, and heroin at another 20%. The blue bars on the graph are opioids. So there was also nearly 10% of the cocaine deaths had oxycodone on board, and 8% had codeine. In addition, 21% had the benzodiazepine, alprazolam, or Xanax, and 7% also had methamphetamine on board. So this suggests a key trend of the present day, and that is cocaine's role in polysubstance abuse patterns, whether it's intentional or unintentional with contaminated fentanyl cocaine. This graph shows the number of border seizures by U.S. Customs and Border Patrol in recent years that have been running relatively steady, nearly 34,000 kilos in 2017, of which nearly 13,000 were along the southwest border. But these are just border seizures. The high-intensity drug trafficking areas, or the HIDTA system, reports much more numbers of cocaine seizures in routine arrests, both in local, state, and federal arrests, going from about 50,000 kilograms of cocaine seized in 2013 up to over 160 in 2017. And the location of those cocaine seizures by HIDTA networks or areas are shown in this map. And the larger the blue dot, the more seizures that took place, but we see that this really is a national phenomenon. This graph just summarizes the both HIDTA production quotas in the blue line and shown on the left-handed axle, and on the right-handed axle are the number of deaths. And we see these paralleling as the supply increased, a direct relationship with the increasing numbers of deaths associated with cocaine. More recently, we've seen headlines about fentanyl-contaminated cocaine. First in January of 2018 in Florida by the DEA, and then Philadelphia, New Jersey. We're going to hear more about cases from New York in just a few minutes. Probably the best measure of what's going on with fentanyl-contaminated cocaine comes from the DEA's National Forensic Laboratory Information System of crime lab data, which showed in 2016 that there were 22,000 crime lab cases that contained fentanyl as the only drug, and another 8,000 that contained fentanyl in combination with heroin, another 1,300 with fentanyl and other opioids, nearly 500 with fentanyl and cocaine in the same drug sample, another 600 with fentanyl and other substances, and 492 that contained fentanyl, heroin, and cocaine, all three drugs in the same drug sample. We looked at the changing patterns of cocaine epidemics, and last month we reviewed the patterns of pharmaceutical stimulant epidemics in our March webinar with NDEWS, and also looking at the role that methamphetamine played in between these periods. And if we also add to this the whole total scene with the opioid epidemics that we've seen over the same 140 years, we get a picture when we put all of these on the same graph that looks something like this, in a solid red showing the periods of cocaine that we've looked at previously from 1880 to 1920. And then as we move into the laws and the law and cocaine activity During the Depression and World War II and post-war years, we see the rise of pharmaceutical stimulants, and more recently with Adderall and misuse. And as prescription stimulants are brought into strict control in 1970, we see the introduction of clandestine illicit methamphetamine. And we add to all of this the opioid epidemics of the past 140 years. And we see that at the present time, we're really at the highest levels. So this is an example of what we're really seeing in 2019, and that is a major polysubstance abuse epidemics, whether being used intentionally or unintentionally. And I thank you so much for your kind attention. And now let's visit our two Sentinel sites for this special report, beginning with New York City. Denise?
Good afternoon, everyone. So I'm going to be speaking about trends in substance and cocaine overdose deaths in New York City. This presentation will start with an overview of unintentional overdose deaths in New York City from 2000 through 2017, followed by an overview of polysubstance involvement in overdose deaths. And this will be followed by a description of trends in cocaine overdose deaths over time, as well as a description of the demographic characteristics of decedents. So this slide here is showing our unintentional drug poisoning deaths from 2000 through 2017. And the blue bar represents the absolute number of overdose deaths, and the pink line, the rate per 100,000 New York City residents. And on the far right-hand side, you'll see that in 2017, there were 1,487 unintentional overdose deaths in New York City, with a rate of 21.2 per 100,000. The rate of unintentional overdose deaths increased for the second consecutive year, more than doubling from the rate of 8.2 in 2010 to the 21.2 in 2017. And while we reached the highest rate and the highest number in 2017, we actually are seeing a slowing of the rate of increase in New York City. From 2015 to 2016, the overdose rate increased by 51%, while from 2016 to 2017, it increased by only 2%. Based on our preliminary 2018 data, we expect to observe about the same increase from 2017 to 2018. Opioids were involved in 80% of overdose deaths in 2017, and nearly 3/4 of the overdose deaths involved heroin or fentanyl, and about half involved cocaine. And we've observed over time in the last few years a decrease in the proportion of overdose deaths involving benzodiazepines. Opioid analgesics were down to 14%, and methadone 13%. Importantly, most of the overdose deaths in New York City, more than 90%, involve multiple substances. And the use of multiple CNS depressants, such as opioids and benzodiazepines, increase the risk of overdose deaths. So you can see here that over half of the deaths in New York City involve multiple central nervous system depressants. Polysubstances, I'm going to show you by most common combinations that we saw in 2017. So of the 1,487 drug overdose deaths, 38% involve cocaine and opioids, 34% alcohol and opioids, and a little more than a quarter, 27%, involve benzodiazepines and opioids. Well, fentanyl, when I refer to fentanyl, I'm talking about fentanyl, any kind of fentanyl analogs. And in 2017, for the first time, fentanyl was the most common substance involved in drug overdose deaths, and it was found in 57% of all of all of the overdose deaths in New York City. The increased involvement of fentanyl in overdose deaths placed renewed significance on the contribution of multiple substances. So what's driving these historic increases? And you can see here from this slide, this is showing overdose deaths by quarter going back to 2015. And there has been an increase in the proportion of overdose deaths per quarter through 2017. And prior to 2015, not more than 4% of the deaths involved fentanyl. And now, as I mentioned, we're over 57% in 2017. So fentanyl is involved in the vast majority, 69% of the heroin overdose deaths in New York City also involved fentanyl. And furthermore, fentanyl was involved in over half, 53%, of the cocaine overdose deaths in 2017. So now I'm going to talk a little bit about cocaine overdose deaths in New York City. So in the previous section, we showed the high prevalence of substance contribution to fatal overdose, and specifically the high proportion of overdose deaths which involve fentanyl. This next section of the presentation will focus on the trends in cocaine and overdose deaths, and we'll show that the rate of cocaine overdose deaths has increased dramatically over the past few years, partly driven by the increased involvement in fentanyl. So as you'll see, this slide, similar to the one of all overdose deaths in New York City, shows the data in the same way. The blue bar, the absolute numbers, and the pink, the rate per 100,000. And it shows a similar trend to any drug-involved overdose deaths. But in 2017, on the far right-hand side, we see that there were 732 unintentional overdose deaths that involved cocaine, with a rate of 10.5 per 100,000. The rate of cocaine overdose deaths increased significantly, almost doubling from 2015 to 2017. Prior to that period, the rate of cocaine overdose deaths from 2010 to 2014 was relatively stable, averaging 4.9 per 100,000 during this time period. So we've seen a significant increase. This slide here shows that the rate of cocaine overdose deaths overall in the blue line, and the rates of cocaine overdose deaths involving fentanyl in pink and green from 2010 to 2017. So starting in 2015, fentanyl was increasingly present in cocaine overdose deaths. Prior to 2015, fentanyl was involved in less than 5% of cocaine overdose deaths. But from 2015 to 2017, the rate of cocaine overdose deaths involving fentanyl increased from 0.9 per 100,000 to 5.6 per 100,000, shown in the pink line. We look at the number of cocaine overdose deaths which involve fentanyl but no heroin to estimate deaths where fentanyl might have been present in the cocaine product. Of course, we can't confirm that with mortality toxicology. We do, however, have lab data from NYPD, and we can confirm, because we do have a denominator, that 2% of cocaine products seized by NYPD tested positive for fentanyl. So we always assume that when heroin and fentanyl are both present in overdose deaths, it's likely that the fentanyl was mixed into the heroin product. But we did find that 1/5 of the cocaine overdose deaths in 2017 involved fentanyl and no heroin, an increase from 4% in 2015. So from 2015 to 2017, the rate of cocaine overdose deaths involving fentanyl and no heroin increased from 0.3 to 2.2 per 100,000, and that's shown in the green line. Cocaine and fentanyl, but no heroin. Now, focusing a little bit on demographics, Black New Yorkers had not only the highest rate of cocaine-involved overdose deaths in 2017, as you see in the pink line. The rate was 15.5 per 100,000 residents, but they also experienced the largest increase in cocaine-involved overdose deaths from 2015 to 2017. So in 2015, the rate of cocaine overdose deaths was similar across Black, Latino, and white New Yorkers. But from 2015 to 2017, the rate of cocaine overdose deaths among Black New Yorkers more than doubled, from 6.4 to 15.5 per 100,000, a significant increase. And this slide is showing that cocaine involved in greater proportions of overdose and overdoses among Black New Yorkers. So the burden of cocaine overdose death is also highest among Black New Yorkers. While cocaine was involved in half of overdose deaths among Latino New Yorkers and 40% of overdose deaths among white New Yorkers, cocaine was involved in 61% of overdose deaths among Black New Yorkers. So this suggests that overdose prevention initiatives, which focus solely on preventing opioid overdose deaths, may in fact increase racial disparities in overdose deaths, and we need to pay attention to that in the prevention work that we do. So more broadly speaking, in 2017, rates of cocaine-involved overdose deaths in New York City were significantly higher among males than females, with a rate of 17.4 versus 4.3. Was also highest among Black New Yorkers, as I just stated, and also the rates are highest among New Yorkers ages 35 to 54. So in conclusion, for the polysubstances, most overdose deaths, as I stated, more than 90% in New York City involve multiple substances, and over half of overdose deaths involve multiple CNS depressants. Fentanyl is increasingly common in heroin, but also in cocaine overdose deaths. And regarding cocaine trends, we've seen an increase in cocaine overdose rates driven by an increase in fentanyl involvement here in New York City. Individuals who use cocaine but no opioids are disproportionately susceptible to risks associated with fentanyl because of lack of tolerance. The burden and the rate of cocaine overdose is highest among Black New Yorkers, and overdose prevention initiatives need to reach people who use cocaine. Thank you. I'm going to now turn it over to Marcy.
Yeah, and my messages today are very similar, really, to what we've been hearing from Florida and New York, surprisingly similar. I'm going to be talking about the historical and current patterns in Maine. My objectives are really going to be to summarize those patterns and focus on the drug combinations that are being used. I'll be looking in particular at the deaths, the arrests, law enforcement seizures, and also drug-impaired driver toxicology. An overview of what we're going to look at today. Maine cocaine indicators have been rising since 2013, but they need to be viewed, and these trends need to be viewed in the context of opioid misuse. in particular non-pharmaceutical fentanyl, fentanyl analogs, and heroin, as well as a minority of selected pharmaceutical opioids. I will be demonstrating that cocaine is most commonly used in very patterned combinations, particularly associated with fentanyl now and fentanyl analogs. Maine, if you haven't been to Maine, I welcome you to come up and visit. We are a very rural state with low population density, about 43 people per square mile. There are only 1.3 million in our population, over 30,000 square miles, and we're the oldest in the nation, a dubious distinction. Median age of 44.6, 95% white, so we won't be seeing any of these racial differences. There aren't enough sample size to count them. We've got borders that are different from other states. We have 600 miles of Canadian border. We are getting, for example, methamphetamine shipped in from the Canadian side of things. We have about 200 miles of ocean, the Atlantic Ocean. If you actually count all the little inlets, it's about 3,500 miles of coast. And we share a border of about 170 miles with New Hampshire. Maine has a centralized medical examiner system, one office and one morgue. Investigates all the suspected drug overdoses statewide. All of these overdoses receive comprehensive toxicology testing, which includes a screening and a confirmatory toxicology test. A minority are brought in for autopsy. That's gone down quite a bit with the opioid epidemic and the lack of resources to autopsy all the drug deaths. The death certificates on overdoses will mention all the toxic level drugs and any potential synergistic drugs as well that are confirmed in the forensic toxicology testing results. Cocaine, when it's found in toxicology, is generally mentioned as a cause or less often as a significant contributor on a death certificate. So we're finding pretty much all the cocaine mentioned on the death certificates. Just to open up the indicator trends, I'm going to talk a little bit about a 2018 report from the Maine Drug Enforcement Agency, which investigates about 60% of the drug arrests in the state. Cocaine and crack was included as one of the top drug threats, and it is related to heroin and fentanyl threats. The sources of these drugs are Mexican organized crime and drug cartels. Mid-level distributors are the Dominican criminal drug trafficking organizations, and they are trafficking cocaine, heroin, and fentanyl. National street gangs are involved at the local level, largely coming from south of here, New York, Connecticut, some in Massachusetts. Recent cocaine arrests that the Maine Drug Enforcement Agency provides as examples of 2018 include arrests connected to New York, Rhode Island, and Florida. We are connected by Interstate 95 all the way to Florida, and this is a highway for drugs as well as people. This graph shows the trend in arrests for cocaine and crack between 2006 and 2018. And you can see we were at a higher level in 2006 and 7, with a plunge down to 2014 at the low point. with 12% of the arrests for cocaine and crack. That has increased 175% to 2018. We are now at 33% of the MDEA arrests that are for cocaine and crack. We see a similar curve, at least on the right, for Maine drug-impaired drivers. They receive a urine toxicology test when they're detained, and this graph shows the percent of cocaine-positive toxicology. The low point over on the left is 9%, and it has risen 167% to 24% in 2017. We don't have the 2018 numbers yet. We also see an increase in the law enforcement seizures for cocaine. It's less dramatic than for the arrests and the impaired drivers. But we've got a 64% increase in between 2010, when there were 769 items tested that were testing positive as cocaine, to 2018, when there were 1,263. I'll be taking a closer look at the seizures and their toxicology and what drugs are involved. This graph is also from the law enforcement seizures. What we're looking at here is things that are found in addition to cocaine in the samples. And so we have, for example, levamisole, which is the blue line, which is an adulterant that was added at the point this graph begins in 2010. The levamisole was at 10% of cocaine seizure items. And so you can see that it has fallen down to 0 in 2017 and 18. The graph, therefore, just reaches 10% here. It's only 10% of samples. The sample number that we're talking about is between 900 and 1,200 samples tested per year in Maine. We also have two other lines here. The red line is for heroin, that is to say samples in which heroin and cocaine are found. And the green line is heroin and fentanyl. And not surprisingly, the fentanyl and heroin show the same kind of curve that we will see with the deaths and other indicators. The bottom line of this is that only 1 to 2% here of the recent samples include also heroin or also cocaine, also fentanyl. And this is a look at the deaths. This is, I've included the key illicit drugs as well as pharmaceutical opioids as a category, looking at 2010 to 2018, 3/4 of 2018. The heavy green line is the cocaine line. And if you look at the cocaine row down here, in 2013, we're at a valley with only 10 deaths, and that increases over 800% to the current time, 2018, with 95. What's also going up, as in New York and Florida and nationally, is the heroin, deaths due to heroin and deaths due to fentanyl. And pharmaceutical opioids are sort of plateaued until very recently, when they have started to reduce. The overdoses due to cocaine are 72% male with an average age of 39, so very similar to the New York demographics that you were seeing. Looking at the combinations in the drug deaths, these are not the toxicology results, but rather I'm talking about the drugs that are listed on the death certificate as causes of death. We have 71 deaths in the first 3 quarters of 2018 that included cocaine as a cause. Fully 97% of these 71 deaths had other drugs included as a cause of death besides cocaine. Usually the wording goes like this. Here's an example: acute intoxication due to the combined effects of, and then you'll find a list of drugs that would include cocaine. 68% of these had 3 or more drugs listed as a cause of death. So we've got polysubstance causing the death. In fact, among those 71 deaths, there were 42 unique combinations of drugs. Every which way that you could vary it. Some had more than one opiate involved. Some had another stimulant involved. Some had tranquilizers. Some had other drugs that were just happened to be there. 82% of the drug deaths recently have cocaine plus fentanyl. This is 82% of the cocaine deaths have cocaine and fentanyl or fentanyl analogs. That's quite a few. 38% of them have not only cocaine and fentanyl, but also heroin or other fentanyl analogs as a third drug. Only 10% include cocaine and a pharmaceutical opioid. So pharmaceutical opioids are not playing a major role in the cocaine deaths. This is a comparison table comparing these variables between the impaired driver toxicologies and the deaths. You can see in the first row that the number that are combined, or the percent that are combined with other drugs, is almost the same, 96% in the drivers, 97% in the deaths. 84% of the impaired drivers had 3 or more drugs that showed up as positive in their toxicology. In the deaths, it's 68%. Cocaine and fentanyl or fentanyl analogs, 32% of the impaired drivers had that combination, and 82% of the deaths. If you look at the cocaine, fentanyl, heroin combo, that's 23% of impaired drivers and 38% of deaths. That's more similar. And the pharmaceutical opioid cocaine combinations, 22% for the drivers, 10% for the deaths. My point here is that these are a lot higher in percent than what you were seeing in the law enforcement toxicology items for the seizures, and indicates that the users are in fact mixing these drugs, and that they are not necessarily mixed in the drug that's being trafficked. This slide is a composite of the kind of pattern that we are seeing in Maine in the cocaine deaths. There's at least 3 components to this pattern. Probably in terms of the cause of death, the opioids are in the driver's seat. They're playing the major role, especially if there's fentanyl on board. But what we find is that there's this 3-part combination with a stimulant, an opioid, and a benzodiazepine or similar type of drug. So most of the time we find cocaine, or sometimes it's methamphetamine or amphetamine or pseudoephedrine. The opioids are mostly illicit and non-pharmaceutical opioids, but we're also seeing among the pharmaceutical opiates, buprenorphine, methadone, and oxycodone are the primary ones. Interestingly, the impaired drivers had quite a lot that had buprenorphine as the opioid on board. Then there's a group of benzodiazepine or downers, sort of including benzodiazepines, gabapentin, diphenhydramine, sertraline, hydroxyzine. All of these tend to be on board along with an opioid and cocaine or other stimulant. So this pattern of three is very common amongst these deaths and amongst the impaired drivers. A summary of what we've just been talking about for Maine. Cocaine indicators have been rising since 2013. There was an initial rise along with an increase in heroin, which preceded by about a year the big increase in fentanyl, non-pharmaceutical fentanyl and fentanyl analogs. But cocaine is associated with both of them and should be viewed in the context of illicit opioid misuse. We are seeing cocaine used in patterned combinations of polysubstance. Overdose decedents and drug-impaired drivers frequently combine cocaine with opioids and tranquilizer-type drugs in patterned ways. And the drugs are probably, in most cases, being combined by users after purchase, since the tested seizure items have a much lower frequency of combinations of these drugs. I'd like to acknowledge the people who helped me by providing data or helped me by helping with the analysis. And I'm very grateful for that assistance. Okay, that's it. Just a moment, I'll get out of here.
All right, thank you, Marcy and Jim and Denise. You certainly provided a lot of very useful information and touched on some important and valuable topics. So I'm sure that you have engendered a lot of discussion and thought. And so I'm going to switch back over to our slides as we get started on our Q&A session. And I just want to remind everyone that we will be putting a copy of everyone's slides up on the website, along with a recording of this webinar at NDEWS.org, NDEWS.org. And you can also visit the website if you're interested in any additional information about Maine and New York City, who you heard from today, or any of our other NDEWS Sentinel sites as well. Their annual site reports are available on the website. And these are the other sites that we have available. You'll remember Atlanta and Texas and Los Angeles from our last webinar when we talked about methamphetamine. And so I'm going to pull up the questions now, because we did get a few questions in from our viewers. So thank you for that. And so this first question is for New York. And the question is, how are the unintentional death determinations made?
So we here at the health department link our death certificates with the medical examiner's office files. So we report the cause of death and the manner of death that's determined by the medical examiner, and we report out on the toxicology findings. And with that, we only report unintentional in New York City when we're doing our surveillance.
Okay, thank you. And I think our next couple questions are appropriate for all of you. So whoever feels like you have an answer, please speak up. So first we have, do we know what proportion of cocaine polysubstance use is intentional and what proportion unintentional?
The answer is simply no. But that question is probably the primary question in terms of substance abuse issues in 2019. And I think we've seen, just even from the examples that we saw today, that we have here both a pattern of unintentional use by consumers of products that they don't know what they're buying, but that's a much smaller proportion of these polysubstance cases than those who are intentionally using multiple drugs either simultaneously or sequentially over a few days even, or a few hours, so that the toxicity builds up even though the active effect of the drug may not be present.
Yeah, and I can comment on the Maine statistics. Almost none, my statistics did include both suicides and accidental deaths, but we have almost no suicides that involve cocaine.
All right, thank you. And here's one more question. Do you have any statistics on the percentage or types of drugs that may come into Maine over the Canadian border or via the seacoast? So this is for you, Marcy.
Yeah. Primarily what we're getting from Canada is methamphetamine. And that's coming from obviously south and through Canada. So that's the Canadian border. The Atlantic Ocean is a little harder to quantify, but involves, I think, pretty much the same pattern of types of drugs that we're getting overland. So it would include a mix of cocaine, opioids, sometimes pharmaceutical, but mostly non-pharmaceutical.
All right, thank you very much. So I'm going to just pull up a brief poll here, which I hope that those of you who are sticking with us will take a few moments to fill out. It's just 3 short questions to give us some feedback on today and topics you may be interested in the future. And in the meantime, we did just have a few more questions come in. So I'll move on to another question, which is, do we know at what point or what extent fentanyl is being cut into cocaine?
My data show that very little of it is cut before the user is using it. And, but after, the user combines, then a lot of the cases have fentanyl and cocaine. I think, I don't remember right now exactly, but I think it was in the 60%.
Right, so I had reported here in New York City that we know from the lab data from NYPD that 2% of the cocaine products were cut with fentanyl.
So very similar to Maine.
Yeah.
All right, thanks for that information. Our next question is, with the recent discussion of CBD blocking cytochrome P450 metabolism, do you anticipate an increase in deaths given that fentanyl and cocaine are also metabolized by the enzyme? Any of you have anything to contribute to that one?
I don't, and it's an interesting question.
It is, but it's rather specific. Okay, so we'll see if we can find something offline for that one. And our last question here is from someone who would like to know, do you have an estimate of the proportion of substances seized by law enforcement that are submitted for lab testing?
I already mentioned, I think, that when a number of drugs are seized, if one of those drugs is cocaine, frequently cocaine is the one that is selected for testing because the sentence rules for cocaine are higher. In other words, it's a harder sentence that's given in the courts. So cocaine, there's a bias for cocaine.
It's about 30%, I think, in New York City, but we can get back to you and confirm that.
Okay, thank you. We just had a couple more questions come in. One comes from somebody, a viewer, who notes that it appears there is a simultaneous crisis occurring at this point in time. Historically, have opioid and stimulant crises been sequential?
Well, not necessarily in terms of major epidemics, but certainly cocaine and heroin combinations have been around for years. So the patterns that we're hearing about are probably exemplified by the higher toxicity of particularly fentanyl and fentanyl analogs. So people might be taking the same patterns and combinations that they have for previous years, but now they're more likely to die.
Okay, thank you. So we have one last question here from a participant who would like to know, does the medical community still recognize any medical benefits of cocaine that were promoted back in the early 20th century?
Cocaine is still available to use for surgery as a local anesthetic in nasal and oral areas.
I don't think it's being used very much. I know that it was used in the 70s and 80s. I have not heard any medical use recently myself. I know it's still a possibility.
Yeah, I would agree with that.
Okay, thank you very much, everyone. On that note, I want to thank you all for joining us this afternoon, and thank you to our presenters. We're sharing some powerful presentations and a lot of valuable information, and I hope that all of you will be able to join us again for our next webinar, which will be on May 22nd at 2 p.m. Eastern, when we will be joined by Dr. Margaret Warner, an injury epidemiologist at the CDC National Center for Health Statistics, who will be discussing recent enhancements in the timeliness and specificity of drug overdose death certificate data from the NCHS. So keep an eye out on our website and on the network for our announcements and register for our upcoming webinar. And we look forward to seeing everyone again. And thank you to all of you for joining the webinar and submitting your questions. And we will see you next time, and have a great week.